Welcome and thank you for standing by. All participants are in a listen-only mode. Today's call is being recorded. If you have any objections, you may disconnect at this time. My name is Lisa Wagner, and I am on the policy team at the National Center for Health Statistics, or NCHS. Today is World Statistics Day, and we are excited to honor this day at NCHS as the nation's health statistics agency. We are highlighting a unique program at NCHS, the Data Linkage Program. I am pleased to introduce today's speaker, Lisa Merle. Lisa is the Chief of the Data Linkage Methodology and Analysis Branch in the Division of Analysis and Epidemiology. Lisa directs the NCHS Data Linkage Program, leading efforts to integrate NCHS data collection systems with external sources of health-related administrative data to both expand the analytical potential of NCHS data and to develop innovative data resources that better inform public health policy and fill critical information gaps. Lisa's work has focused primarily on integrating multiple sources of data through data linkage and advising on survey design and estimation techniques for large-scale national health surveys. Lisa will provide an overview of the data linkage program at NCHS and present on some of the useful ways linked data are being used and have been used to address key health policy questions. We see the data linkage program as a key area in data modernization and the implementation of the Evidence Act. The presentation will be followed by a question and answer session. Just a reminder, the audience is currently in a listen-only mode. Questions or comments may be entered through the Q&A feature, and we will address them as time permits during the question and answer session. And now I turn it over to Lisa.
Great, thank you, Lisa, and good afternoon. I am really pleased to have this opportunity to present information about the Data Linkage Program at NCHS, and I'm even more excited to do this on World Statistics Day. So as Lisa mentioned, I have been directing the NCHS Data Linkage Program since about 2016. And before getting into the talk, I really want to point out that none of this work could have been done without the fabulous team that we have here at NCHS. Our team links the NCHS survey data with health-related data from vital and other administrative records. To start off with, I wanted to provide just a bit of background about NCHS. As Lisa noted, we are the nation's principal health statistics agency, and we are part of the Centers for Disease Control and Prevention. We're located outside of Washington, D.C., and on this slide, I have included a picture of our building in case you ever want to come and visit. We are one of 13 principal federal statistical agencies, and our mission is to provide timely, relevant statistical information that can be used to guide actions and policies to improve the health of the American people. With the NCHS mission in mind, I am now going to discuss how the data linkage program here at NCHS can really be a tool for evidence-based policymaking. There are many pressing policy questions, and in order to answer them, you really need some complex and detailed data. This slide lists some potential policy questions, that may need some data resources to help answer them. For example, do Social Security disability insurance beneficiaries have access to care during the waiting period before they receive Medicare? Other questions might be, are there adverse health effects associated with the mandatory folic acid fortification policy for grain products in older adults? Or how effective are health policies in reducing lead exposure? So in order to collect data that would be able to answer these types of questions, there's so many more, but these were just a few examples, it would be very time consuming and expensive. But given the difficulty of finding one data resource that could answer these key policy questions, we start thinking about linking sources. And if you think about linking data, it truly is a powerful mechanism to provide policy relevant information in an efficient way. At NCHS, we collect health survey data, and these data are collected to monitor health status, well-being, and healthcare access. Oftentimes, these types of data are referred to, to be used for surveillance purposes or for research purposes. And then on the other side, we have administrative data, which are collected for programmatic purposes. But by combining these two types of existing data, we can efficiently create opportunities that can really help answer key health and policy relevant questions. So how do we combine these sources? What I wanted to do on this slide is to kind of show a schematic of how the linkage process works. And, as I was putting this together, I was thinking, oh, it'd be so nice if it were just this easy. We have two boxes, we put it together, and then we're done. But what this depiction shows is how we have our survey data on one side, and on the other side, we have our administrative data. In our program, most often we collect our linkages at the person level, and we use personally identifiable information, or PII, to connect the two sources. So as you can see here, we have the personally identifiable information that we get from the survey data collection. And then we also have that type of information in the administrative data. These types of data can include social security number, name, date of birth, sex, or other types of information. And then we have this middle box, which I have highlighted in red, and that is where the linkage occurs. A lot of methodological work goes into that box. We use both probabilistic and deterministic techniques to put these sources together. We assess alternate records in an attempt to correct for potential quality issues with reported identifiers. And we look into the most efficient ways that we can really conduct these linkages. Ultimately, we end up with a linked data set that includes both matches and non-matches. So if you kind of look to that side of this flow chart, if you think about, we link, because one of the sources that we link to is the National Death Index. And so we have survey participants who may have died in future years after the survey. And we have information about, who has died and then who hasn't. And so we take that information of both the people who have matched and not matched to run detailed analyses on the associations with the outcomes. We also have this box on the far right that represents the non-matched administrative records. This means that there's people in the administrative data set that we do not actually have in our surveys. That means that our survey participants are not receiving that benefit that would be found in the administrative records. And they're not expected to match, but there is still this chunk of people who have non-matched administrative records. So our goal after putting these sources together, coming up with these linked data sets, is to really release a linked data file that contains high quality matches with low type 1 and type 2 errors, or false positives and false negatives. And so that's really what, a very high level overview of what we're doing in our program here at NCHS. On this slide, I wanted to note what surveys are included in our linkage program and tell you a little bit of background about each one. The first survey I listed here is the National Health Interview Survey, or NHIS. It's a nationally representative cross-sectional household interview survey that serves as an important source of information on the health of the civilian non-institutionalized population. We also work with the NHANES data, which is the National Health and Nutrition Examination Survey. And this is a nationally representative cross-sectional sample of the US civilian non-institutionalized population. And similar to HIS, they have a household interview, but what makes NHANES unique is that it has a physical examination component that takes place in a mobile exam center. We also work with National Healthcare Survey data, and the National Healthcare Surveys are a family of data collection efforts that gather information about providers of healthcare services and the patients that they serve. And this is across the spectrum of healthcare settings, from ambulatory and hospital care to long-term care settings. So the surveys collect a vast amount of information. And this slide definitely does not do justice to everything that we've collected during our surveys, but I did just want to highlight it just to kind of point out types of information that you're going to be getting from the survey side. We have information on health behaviors. So this could include, whether or not somebody smokes, what is their alcohol use, are they obese, what types of physical activity do they take part in. We get information on their health and their well-being and their functional status as well. We also get information about health conditions and comorbidities. There's many questions, has a doctor ever told you that you have this condition? And there's a lot of self-report on that. We have information on socioeconomic status. We have income, education, information about occupation or the industry that somebody may have worked in. And there are questions about healthcare access and utilization that are collected as well. However, not all of our survey participants or our patient records that we get from the healthcare surveys are eligible for linkages. And I do like to point out that linkage eligibility is distinct from thinking about program eligibility, where that would be more, and if you think about those two boxes in that flow chart, that would be more on the administrative record side. But right now I'm talking about on the survey side and so only NCHS survey participants who have provided consent as well as the necessary personally identifiable information are considered linkage eligible. So those are the only people that will then go into that red box of getting part of the linkage algorithm. Our survey participants are informed about our intent to conduct data linkage activities through a variety of informed consent procedures. It could be an advance letter, participant brochure, signed consent forms, and even as part of the questionnaire. So I do like to highlight, because I do find that often when I present on this material, people are interested, well, how many of the survey participants are considered linkage eligible? So I wanted to show an example looking at the NHIS, or the National Health Interview Survey, and looking at a range of years from 2004 to 2015. And we see that, in the earlier years that I have on this graph, 2004 to 2006, our linkage eligibility was only around 50%. So that was, participants just not having quite enough PII or consent for linkage. But around 2007, there was a change in how the data were collected related to linkage. We started asking for less identifying information, meaning we just started asking for the last 4 digits of participant social security number. And we also had a direct question about whether or not they consented to have their survey data linked to health-related administrative records. And now you can see we're hovering around 90% in terms of who is considered linkage eligible, which is, so those are the people that are then going into the linkage algorithm, and, we are attempting to link them to the administrative data sources. I wanted to turn now to the administrative data sources that we link the survey data to. I'm highlighting the 3 main sources on this slide, but we are in the process of adding new sources that we're going to be using in our linkages. And I'm going to touch on those later on in the slide deck. So the main linkage that we do, the main in the sense that is the most utilized, is we link our survey data to the National Death Index. The NDI is it's a centralized database of US deaths gathered from states' vital statistics offices. We also link to Medicare and Medicaid data from the Centers for Medicare and Medicaid Services. These type of data provide information about health insurance and healthcare coverage for those who are 65 and older and some vulnerable populations in the US, including low-income children and the aged or disabled poor. And we link also to housing and urban development administrative data that tells us information about receipt of federal assisted housing. HUD is responsible for overseeing and managing domestic programs and policies, including special ed programs for high needs populations in the US. So as a summary, I wanted to provide this slide, which really illustrates, how our linkages are done and what sources we link to. So if we focus just on that purple box right now, we have our NCHS survey data. So this includes our survey participants represented by the little people in the box, and those are coming from our population-based household surveys. We also, if we think about our national healthcare surveys, we're sampling, typically at that hospital level is being sampled, but then we get patient records from the sampled hospitals. And this is the National Hospital Care Survey, which I will talk about in a bit as well, that we've used in our linkages. And we've linked these sources on an entity-to-entity basis, or at a person level, to the sources surrounding. So if you look in the orange box, this is highlighting the mortality linkage and linking to the National Death Index, where we're getting information on cause of death, and follow-up time, really, and when we get the date of death. We link with Medicare and Medicaid to get healthcare utilization and expenditure information. And we link to the housing and urban development data, and we get information on the timing of housing assistance and the type that people were receiving. So we've been conducting linkages at NCHS since around 1980, and we continually to update the files that we have as new administrative data become available, as well as new survey data. So this slide is highlighting the availability of the NHIS and the NHANES data. So for the NHIS, if we focus on that orange bar, our linkage to the National Death Index, we see that we have right now about 30 years of follow-up. So the first NHIS survey that was part of the linkage program that we linked data for was in 1985. And so we have NDI data through 2015 right now. We are in the process of updating that to get data through 2019. And that's what these dashed lines or the arrows represent. These are updates that we are currently doing for these 2 surveys. For NHANES, we've gone back to NHANES 3, and then we also have the continuous NHANES. There are earlier NHANES surveys that have been in some of our linkages as well. I just did not depict them on this graph. But I really think it's important to think about how these files are curated, and we try to have them provide an excellent source for researchers to assess trends over time and follow participants as they age. So we do continually, keep the same surveys, add new surveys, and add new administrative data as they become available. So as we continue to update our previous linkages, as I noted on the last slide, we also continue to expand. And we're really building on some of these past successes as we continue to be known more in the federal statistical world, and has really brought us some really great opportunities, of which I wanted to note 2 recent releases of a unique and innovative set of data. So we have recently released linked electronic health records and claims data from the National Hospital Care Survey, and we linked that with Medicare data to provide a new resource for patient outcomes research. And this includes evaluating treatment effectiveness and post-acute care utilization. And we've also linked these same data with death certificate information from the National Death Index to assess 30, 60, 90-day post-hospitalization mortality. I included the link on this slide if you wanted to just check out information about this linkage. And I also included this screenshot of a recent National Health Statistics report that was put out. I know it's a bit small, but I did just want to highlight how these data have been used. This report looked at opioid-involved emergency department visits and subsequent mortality. And the authors found that for approximately 22% of patients who died of an opioid-involved drug overdose in 2014, that their last emergency department only visit or hospitalization was opioid involved. So that's just an example of how how that linked data set can be used. So in addition to the example that I just mentioned, the linked data have supported an incredible amount of research, epidemiological research, that supports more than 950 peer-reviewed publications and government reports. The way that I've set this slide up is I showed just a few examples of titles that have come out of people who have used our data, and then the journals where they have been submitted and reported in. So if we just look at a couple examples from each one, the linked mortality data, people have looked at deaths associated with being underweight, overweight, or obese. If we looked at the Medicare or the CMS linked data, it has both Medicare and Medicaid in there. People have looked at health service use among the previously uninsured. So we'd have information, from the survey data if people had insurance, and then once they've linked to Medicare that they are now getting Medicare as their health insurance coverage. For the linked NCHS and HUD data, I'm going to talk a bit more about the housing assistance and blood lead levels in children, and there's also been examples looking at cigarette smoking and adverse health outcomes among adults receiving federal assisted housing. In the next few slides, I am going to go through, how the program creates resources that support evidence-based policymaking. And it's really based on these core principles of the NCHS Data Linkage Program, which are noted here. We link our survey data with the National Death Index and health-related administrative data. We provide documentation on the linkage methodology, the linkage quality, and the analytic guidelines that accompany each file. And as I kind of pointed out with that, the timeline chart, that we're releasing these curated data that can be used for multiple research projects and hopefully be used, maybe to replicate findings of other researchers or look to see if certain trends are still there. So I wanted to walk through 3 specific examples where the linked NCHS data have been used. And what I'm going to present is not necessarily research that has been conducted by NCHS staff, but they have been using NCHS linked data. So for all of you listening, I'm really hoping that these examples might spark some ideas of how you might be able to use the linked data to answer some key questions that you have. And to really note that our program is making these resources available, as a public good for public health research. So the 3 examples are the way the linked data have been used by researchers to support policy evaluation. So the first kind of ties back to those first 3 questions I brought up at the very beginning of the presentation. And this is looking to see, or assess this mandatory 24-month waiting period for Social Security disability insurance beneficiaries prior to their eligibility for Medicare benefits. So given that waiting period, the policy question, or the question that the researchers wanted to answer, was to look to see if SSDI beneficiaries have health insurance coverage and adequate access to care during the waiting period before Medicare entitlement. The authors used the NHIS data linked with the Social Security Administration Medicare and Medicare administrative data. And what they found is that about 1 in 4 of the SSDI beneficiaries reported having no health insurance, with the uninsured reporting more problems with access to care than insured individuals. So this is just a really great example of how this information that was collected as part of the survey could be used to answer this question. Otherwise, if you just looked at the administrative data, you would have no sense really of, whether they had health insurance data prior or whether they were experiencing problems with access to care. In this next example, we really see how important it is to have data that spans over decades. As we know, changes are not always immediate, especially in the field of public health. But what the linked data allow us to do is to evaluate a policy change that, in this example, occurred in the late 1990s, and look to see how that policy change may be having an impact on Americans. So for this example, I kind of like this one because I think many of us can relate to it because of our own consumption of cereal or bread and pasta. And I know in my household, these are definite staples in our pantry. So there is a health policy story behind these products and what it means for both babies and for adults. So the policy was that in 1998, the US Food and Drug Administration required that folic acid be added to enriched grain products such as bread, pasta, rice, and cereal in an effort to prevent certain birth defects. And the researchers were asking, well, are there adverse health effects associated with this mandatory folic acid fortification policy for grain products in older adults? So the sources that they turned to were to use the linked NHANES data, which has a vast amount of information about dietary intake and also includes biomarkers. And they used the NHANES data linked with both Medicare and the National Death Index data to get information about cancer morbidity. So what they found was that in the post-folic acid fortification years, high folate intake and biomarkers in older adults appeared to be protective against cancer compared to lower intake. So this study did not show a negative impact on folic acid fortification on cancer risk. So the last example that I was going to go over uses the linked NHANES and the HUD data. And this example really was a true success story for both agencies. And it has been highlighted in a lot of the work that supported the Evidence Act and some of the evidence-based policymaking discussions. So the policy here was that the U.S. Department of Housing and Urban Development, or HUD, initiated lead-based paint regulations in federal housing. And this was to reduce the hazards associated with lead-based paints in homes. And the authors wanted to look to see how effective are HUD's policies at reducing lead exposure for children living in federal housing as measured by blood lead levels. So the authors used NHANES, and again, as I mentioned, there's the mobile examination component of NHANES where they did a blood draw to assess blood lead levels. And so what they found is that children receiving federal housing assistance had statistically significant lower geometric mean blood lead levels than comparable children who were not receiving housing assistance. So hopefully, going through these examples, thinking about the different sources that we have, I'm hoping that maybe you're starting to think about maybe some amazing projects that you could do with the linked data. And so I thought it would be important to just touch on about ways that you could access these. I've talked about all these resources that we've created, and I wanted to just touch on now how to access them. So we have two types of data for the linked data. We have public use and we have restricted use. Our public use data is more limited than the restricted use data, but I wanted to mention the two that we have. We have a public use linked mortality file. So this file is available on the web. People can download it. They can merge it with the survey data that is public use and start analyses and look at, causes of death, and that types of information. It is a more limited file than our linked mortality file that can be accessed through restricted use, but it does have information on, follow-up time. It has information on causes of death. It doesn't have all of the causes of death, but it has a limited number. And so researchers can really work with those files and get ideas. And then if they want to dig deeper, they could come in the research data center and use restricted use files. We also have what we call our feasibility files. So the feasibility files were created as a way to help researchers assess whether the sample sizes for their analysis can be supported. So basically, the feasibility file has an indicator on it indicating whether or not that survey participant matched. So if we think about the Medicare file, the example I have here, you would have, an ID that you could link back to the survey data, and you'd get information on whether or not that person linked to Medicare and what Medicare files they were on. It doesn't have any information on, any of the Medicare variables. It doesn't have costs, expenditures or utilization, but it tells you whether or not that person is going to be on the linked data set. So for all of our other files, they can only be accessed through the NCHS Research Data Center or a federal statistical research data center. And I believe there are about 30 federal statistical research data centers now that we've partnered with. So I wanted to put up this slide just to show you, it has the link to the research data center. It gives instructions for how to prepare a research data center proposal, the different types of data, and the different access modes. So that was definitely, most of our files are, accessed through the RDC. So before concluding, I did want to mention some of the upcoming linkages and some, potential questions that we've toyed around with that could be answered with these new resources. So these are up and coming linkages that we're planning to do. We are going to be linking the survey data with Veterans Affairs data, and this is going to be the first time we're doing this linkage. We're actually really excited about it. We're hoping that, researchers will want to use these data and look at maybe the health characteristics that are collected during the survey, looking at health outcomes and healthcare utilization for veterans within and outside the VA health system. We are also really looking forward, or really excited about this next one and linking to the Medicaid TMSIS data. So NCHS is really going to be one of the first federal agencies to link national survey data to these newly transformed Medicaid data files. So once the files are linked, we're going to have this unique data resource available and also be able to, offer to the research community, kind of how the linkage went, what was the linkage quality, and that kind of really key information. A question we thought could be answered using the new file would be, how do changes in healthcare policy affect health status for Medicaid recipients? We are also getting very close to linking the survey data with end-stage renal disease data. So this one is really important because even though approximately 1% of Medicare beneficiaries have end-stage renal disease, but I think the reason that it's important to understand this population is that their healthcare costs equal about 7% of total Medicare spending. So what's a neat aspect that we can bring to the table by linking these is, if we think about the NHANES data, we can get, we can look at the association of dietary intake and patients who are diagnosed with ESRD. And for the last one, we're in negotiations right now with Social Security Administration to try to update a linkage with those data. We had linked in the past, as you saw by the example I pointed out in terms of the waiting period for the SSDI beneficiaries, but we are hoping to link to those data again so we can, update that analyses or look at other analyses like what are population health factors that influence disability and unmet needs for SSA beneficiaries. So for the last two slides, I wanted to touch on kind of the future direction or innovative aspects that we are doing right now and thinking about doing within the program, and also touch on our commitment to creating new linked data resources that will be able to support evidence building by providing the linked data. So some of the areas that we're focusing on right now are looking into machine learning. We've done this some, but we want to keep building on this and as ways to incorporate machine learning techniques to improve linkage accuracy and efficiency. We are currently starting a project looking at encrypted linkages or assessing privacy-preserving record linkage algorithms to help increase the linkage activities across the healthcare spectrum. And the last, one of the areas that I'm really excited about is that we're thinking about synthetic data as well to help make these data more accessible to users so that it's not all behind the Research Data Center restricted data. So we're starting to pilot innovative methods for creating these synthetic data files, which hopefully can improve accessibility, but still, limiting disclosure risk. So in conclusion, I just wanted to highlight our commitment to data access for our researchers. We're really trying, like I said, to put out public use files where we are assessing the disclosure risk, but still making sure that they're analytically useful and valid data sets. We have been working on other resources for users. We have e-learning tools. We have a web tutorial and we've just finished updating it and it should be launching shortly. We compile examples, kind of how I showed you on that slide where, we have over 950 publications that have used the linked data. And so we create bibliographies that we post on our website. We update them every 6 months. So for each data linkage, researchers can see what files have been linked, or what analyses have been done using these linked data. And I think doing outreach and increasing our user base, it's part of the reason we're so excited to be doing this webinar today, to let more people know about the resources that we have and that we continue to build on. We're talking with federal partners, policy groups, academics. And so, yeah, I think those are some of the really important ways that we are really trying to show our commitment to this program and hopefully being a great resource for people who need it. So on this last slide, I just wanted to show, all the different ways you could communicate with us, follow up with us after this webinar. Our program has a data linkage inbox or an email that you could always send queries to. We check it every day and we try to have a pretty good response time back, in 2 or 3 days. I included the link to our website. I included my email on here as well if you have any specific questions that we're not able to address during the Q&A. And I also included the NCHS Research Data Center. I included their email address and also their website if you're interested in putting together, a proposal or thinking about how you could access these restricted data. So with that, I will conclude the formal presentation and I will hand it over to Lisa.
Thank you, Lisa. We are now entering the question and answer session. As time allows, the presenter will address questions from the Q&A feature. Please submit your questions through the Q&A feature now. If your question or comment is not addressed, please direct it to paoquery@cdc.gov. That's paoquery@cdc.gov. All right, Lisa. We have several questions already coming in. And so I'll kick it off with one of the first questions asked, I think, early on in your presentation. So the availability of the most recent data for each data source differs. How does this impact the linkage?
So I will try to answer that the best that I can. So, I think it really depends that we treat each linkage independently. And so, if we are linking to the NDI, we take the surveys that we're linking and then we take the years of availability for the NDI. So like right now, I said we are in the process of updating that linkage and we're going to have NDI data through 2019. And we hope to have that out early next year. But at the same time, we're also working simultaneously on updating our HUD linkage. And we have the HUD link data, we have HUD administrative data through 2019. So the idea is that, each one is kind of performed independently, but given that all of the surveys have a unique identifier, the different sources could be combined, that you could analyze the NDI data and the HUD data and the Medicare data if you wanted to put them all together. And again, it would be, for the researcher to kind of look at those timelines and make sure that in their proposal that they were making sure, the time spans were covering the same period.
Great. We did get a few questions early on about data access, which I think you did address some through your discussion on the RDC and public use files. But I wonder if you could just say it again in case these folks do have any other questions about that, about access to the linked data, availability for the public, particularly for the new linked data. So the new the ones that you said that you all are just starting to do or will be coming out soon, and then access to RDCs right now, given the current pandemic?
Yeah, no, those are great questions. And so I mean, just in terms of access, it's like I said, we have a public use linked mortality file, and that, you know, that's a really great resource for people. But it is somewhat limited in that, you know, it only has adults and it only has a limited number of causes of death. I think for most surveys it's about 9. For some of the other surveys with more recent years, we had to limit um, how many causes of death were on there. But because, you know, I think once we link, we link the different sources, there's the potential for a lot more identifiability of survey participants or disclosure risk. So that is the main reason most are accessed through the RDC. But like I said, I mean, you know, kind of as I got later in the presentation, that we are exploring synthetic data mechanisms as a way to make some of these resources more available for people. We are hoping to have, you know, a stakeholders meeting either later this year or early next year to really get a sense of, if we were to try to put out, you know, a synthetic data file that had the linked data, what would be some of the key variables that researchers would want to see, and, you know, what questions would they want to be asking? Because I think putting out a fully synthetic file, there's, you know, I think you can lose some analytic utility when you're trying to put on too many variables and keep a lot of those distributions. So I definitely think we're working towards trying to make the data more available, but as of right now, you know, most are through the RDC. And as you mentioned with COVID, I think some of the RDCs are closed. I think there is some work going on, and I don't want to speak for the RDC, but that some of the RDC analysts can do some of the analyses for researchers. So I would say if that's something you're interested in, to really contact the RDC and those links that I had included right at the end of the presentation.
Great. The next question is around what information are included in restricted linked files compared to the public use files. I think you already touched on that a bit as well.
Yeah, I mean, I think, so one of the things that we do on our website, and you could find it, you know, kind of specific for each linkage, is that we include code books for every, you know, linkage that we do. And so the code books include all of the variables from the administrative records that we have. So, I mean, I want to give the example of the Medicare data that we just recently released that were linked with the hospital care survey data. And there are, I'm not even sure, maybe, you know, 60 code books related to all of the different files, right? So you have the Part D file, you have the MedPAR file, you have all these different files, and it has all of the variables that are in there. So, you know, for researchers, they can kind of go through, peruse, or, you know, and I think that's something where we have our data linkage inbox, and if people do have questions or they're not sure what variables to focus on, we would be happy to work with them in thinking through what variables to include. But I think the example that I did touch on was with the linked mortality file, and that we have, you know, a limited number of causes of death on the public use file, whereas we have, you know, any cause, really whatever they died from on the restricted use file. So we have the top 10 or the top 9 leading causes on the public use, and really all other causes, you know, that you can imagine will be on the restricted use file.
Great. There's a question here on geography.
Okay.
What is the finest level of geography identified for individuals, both on the public and the restricted files?
Yeah, that's a great question. I didn't include anything on our slides about geography, but we actually do geocode all of the surveys as well. So you can get, you know, a geocoded address that could then be linked to other outside sources, like information from the Census Bureau, or, you know, other places that you could bring in information at a geographic level. So the geographic level can get pretty small, you know, but I think in order for somebody to be able to access at a very low level of geography, you know, they would have to put that in their proposal, and kind of, it would have to be assessed by subject matter experts as to whether or not there would be a disclosure risk by having that level of detail.
Great.
Something we could work on.
Um, the next question is around any updates you're doing to the linkage files. The person said you mentioned some updates going on. Are there any updates you're working on for the NHIS and NDI linked files?
Yes, we are currently working on that right now. And so the current file that we have for the NHIS linked to the NDI has death information through 2015. And what we are doing right now is linking all the way through NDI data through 2019. And we hope to have that out towards the end of this year or the beginning of next year. And so those data files will be made available as soon as we're done.
Great.
Yeah.
There's a question here on external communication. How do you think that is the best way to communicate to the general public how important our work is? Do you have any recommendations on how things have worked in the past with data linkage?
I think, I mean, it's actually been wonderful collaborating with Lisa and her team with policy and kind of thinking of new ways to do this type of outreach. But I mean, I think, doing webinars like this, I think it's great letting people know that this resource is available. We try to go, to the different national conferences, present on our work and let people know about it. And really, looking for those opportunities. I've gone to different universities and given guest lectures about our program, trying to get, students interested in using the data. And, I think just as much as you can, trying to find those venues where it's a good fit and making sure to be present and letting people know what we have available and what we're doing.
Great. The next question is around some of the data analysis. Is it allowable to link both the NDI and CMS data to NHANES in the same analysis file?
Yes, definitely. And I think there was the one example about the folate fortification, and they actually did use both sources because it was looking at cancer morbidity. So they were using the Medicare data to see, were there any procedure codes related to cancer, and then also looking were there any deaths related to cancer. So I think most definitely, I think that's kind of the way, and that was sort of the idea behind that depiction I did of the linkages where we had the square in the middle with the survey data and then the sources around, and really, trying to tell that complete picture. If you bring in the HUD data, you're getting information on social determinants of health, you're getting outcomes information, the ultimate outcome of death in the NDI file, but then sort of, in that utilization with the Medicare data. So this picture that's happening, you have your cross-sectional survey, but then can really add in this additional information around it is really one of the goals, and we would hope people would use in combination.
Great. There's a question here on the healthcare survey linkages. The person mentioned our linkage to the hospital care survey and work that you've recently done there. Will there be any linkage to NHAMSIS, so the National Hospital Ambulatory Medical Care Survey?
So I think with those right now, they do not have the personally identifiable information that at the patient level, and so we haven't actually included those, but I do believe there are talks about adding in some of that information, and we have been discussing with the Division of Healthcare Statistics about being able to work with them once that happens. So stay tuned.
Great. There's a question on the new Medicaid linkage. Does it cover all states, the new linkage?
So as many that have submitted to the TMSIS program, I think it is pretty comprehensive at this point. It's partly why we're still waiting. We're planning to start up that linkage mid next year, and we are hoping that more states will have their data and there'll be a more complete set that we'll be able to link to. But I think the idea is that when we put out our methods report with that, we will touch on, what states are included and how complete the data are.
Great. This next question is on any non-linked data. So I think where data are not able to be linked, do you issue any sort of reports or information on the characteristics of non-linked cases?
Yes, that's actually a great question. And we are in the process of putting out a series report, an NCHS report about that and kind of looking at the linkage bias. We put together, and it really does look at the linkage eligibility. And so you're comparing then who matched and who didn't in terms of linkage eligibility. But yeah, all of our releases have match rate tables. So you can see, a breakdown of typically by age, sometimes by race, ethnicity, who linked and who didn't compared to the full survey. Yeah, it's a neat way to think of kind of non-response bias, right? Where you have all this information on the survey and then you have who linked, and then you can use the characteristics on the survey to do sort of those assessments. So.
Great. The next question is again a bit on geography, but I also think on disclosure risk. So if a researcher wanted to link NCHS data to external administrative data, do the external data need to cover a sufficiently large geography? For example, would it be possible to link to administrative data from a single city or state?
So that is really hard. And I think, we typically don't do that with our linkage program. That the idea is that we have these nationally representative surveys, and so we're looking towards or representative sources that we link to. So it's not, and I guess just some clarifying with that question a little bit. We don't actually, you know, outside researchers don't actually do the linkages. That PII of the survey participants does not leave NCHS, so that most of the researchers, the linkages are conducted in-house. But like I pointed out, we are looking into some of these encrypted linkages or privacy preserving record linkages, which may open it up kind of across the healthcare spectrum. But I don't know that we would just have it be, at a city or a state level, where I think the idea would be, for the nationally representative sample that we have, linking to sources that might be representative as well.
Great. What is the wait time to get a response on a request to analyze a data set from the RDC if they're asking for RDC access?
Yeah, I mean, I actually don't know. I mean, we try to be pretty responsive. Our group reviews them as subject matter experts related to the linkage. And so when the proposal comes in, the researchers work with the RDC analyst, and then the proposal goes to the different subject matter experts. So usually somebody, if they're requesting it from one of the surveys, somebody on the survey will review it. If they're using the linked data, somebody in my group reviews it, and then we try to get a response time pretty quickly. Again, it will depend on how complete and how well developed the proposal is, and if there's questions on disclosure risk, there may be some back and forth on, do you really need these variables? I don't know if you could break it down by that subgroup. Would you consider collapsing ages? Things like that. But I mean, I probably want somebody from the RDC to answer it, but maybe 6 weeks in terms of time, again, depending on how well developed the proposal is when it comes in.
Great. Will the integrated weighting factors be generated automatically when you query the data from multiple surveys? So I think this is about pulling in the different survey data.
So if you're working with, let's say you're working with NHIS, so you would have the sample weights for that. I'm not sure if that's the weighting that they're talking about, but you would use the sample weights from that survey. And then, if it's linked to, it depends on it. Let's say you're linking HUD and NDI, that you'd want to go, so there's going to be different eligibility criteria for those two. So typically when we're working with weights, we usually say go with the lowest common denominator. So you'd want to go with the more strict linkage criteria. And if you were going to do any weight adjustments, you would use that strictest criteria. But we would have that all outlined in terms of each linked file has an indicator to include, linkage eligibility. So people would be able to work with the different files and know, this would be the starting point then for who went in for linkage eligibility.
Great. We got a thanks. I think,
thanks.
I think there's a question here. You kind of touched on it, on the increase in the number of survey data you're able to link to based on some of the changes and how you're asking people about the use of their data early on. And so there's a question on the permission to use this data for linkage, and like getting any other specific approvals for specific research questions, and how we've kind of addressed that in our data collection.
Yeah, no, that's a really good question. So yes, there was a change in the questionnaire design and how the questions were asked, and the type of PII that was being requested. And that example was for NHIS, but NHANES as well had a change in their questionnaire. I think they changed it from, just relying on social security number, but then they actually, during their consent process in the household, they ask that question right up front, kind of consenting, are you going to be part of this survey? And then they ask, do you consent to have your data linked to health related records? So there is that process. But for us to conduct any linkages, so that happens kind of on the survey end, but within the linkage group, we actually have what we call an ERB. It's an ethics review board, which would be the equivalent for people listening to an IRB at your agency or your university. And we actually put our whole protocol in to have approval to conduct these linkages. And so we really lay out, we remind, or we work with the ERB and show them that, these were the questions, the consent process that happened. This is how we assess the quality of the PII and whether people are going to be determined eligible and get that approval. And in most of our documentation, we have language that, if researchers want to point to, let's say they're putting a journal article together and, somebody's asking, was this approved? And you can say, well, the NCHS ERB approved this linkage and the protocol. So that is available as well.
Great. So the next question is around some of the machine learning techniques and methods you mentioned. Is there going to be any resources that you put out that people can learn more about that based on the work that you're doing?
Yes, we just submitted a paper to, I think it was the Journal of Applied Statistics, that really outlines the machine learning algorithm that we used in the most recent linkage with the hospital care survey data and the NDI. And it really walks through how we use machine learning to help define the blocks that were then used for linkage. So, we're hoping that that gets published. We do have descriptions of the process in our methodology report that is online and publicly available for people now if they were interested in reading a little bit about that. But we are, really trying to get our information out there. We have another article that we just submitted to a journal describing our pilot assessing synthetic data and how we looked at the results from that compared to the true data or the actual restricted data and did a validation assessment that way.
Great. Next question is, can you talk more about the cryptographic linkage methods that are being developed?
Yeah, so we recently have a project that we're looking at to look at privacy preserving record linkage. And the idea behind that is that you are, creating encrypted IDs or encrypted tokens that are then linked with other encrypted tokens outside. So really, we are very much in the infancy of this project and just trying to do a methodological assessment to see, how well do these encrypted strategies work for linkage compared to our linkages where we've used direct identifiers. So our idea is to have a report to assess the encrypted methodologies compared to using direct identifiers and be able to speak to, the quality of the linkages, how the PII data that you have, how does that feed in, how does that affect the results, and are there implications for secondary research when you're looking at the files that have used encrypted linkage compared to maybe the files that have used direct identifiers. So.
Great. Does the change in survey design over years impact linkage?
Only in the sense of who we might be getting identifying information on. So most recently, NHIS went through a really big redesign, and I think now they are only focusing on, their sample adults and sample children, where previously they had had family members as part of the survey. And in earlier years, we had gotten PII on some of the family members, but it was actually around 2007 where that change happened that we really started just focusing on sample adult and sample children. So, I mean, I guess you could say that it affects linkage in the sense of, who's available. But if the surveys are still collecting PII and going through that consent process, the effect on linkage is kind of minimal, but it would just be the inference, I guess, and who would be able to be included in the linkages.
Great.
Mm-hmm.
How do you all collaborate with the Census Bureau, if you do at all?
So we don't, we collaborate in the sense of, we'd love to share ideas and hear what they're doing, but we don't actually conduct our linkages through the Census Bureau. We do it all in-house. And so there isn't much aside from, the sharing of ideas, I think, and us thinking about the synthetic data. Census had recently put out a synthetic linked data file as well. So we've been, reading and hearing, and looking to what they're doing. So I think maybe more just a sharing of information, but not so much in terms of conducting linkages.
Great. And then this next question I'm going to ask and maybe redefine it a bit. So one of the question is, what are some of the challenges you're facing? And I think I would also put it in the context of what are the greatest opportunities or things that you're looking forward to for data linkage as well.
Yeah, I like that opportunities one. I mean, there's always challenges, right? I mean, I think, one of the challenges, as we saw on that graph where, linkage eligibility has increased, but what that also meant is that we were getting less identifying information. We weren't getting the 9-digit social security number anymore. We were only getting the last 4. And so having less identifying information, it means we need to enhance our, kind of speaking to what you were saying, Lisa, an opportunity, right? It causes us to improve our linkage algorithms, incorporate other techniques. It's, previously we may have gotten away with just doing deterministic linkages. We had an SSN, we had a date of birth, we had gender, and, that was almost sufficient information. But as we got less PII, we had to, incorporate other techniques, going into the more probabilistic area as well, relying on the Fleege Center methodology of record linkage and incorporating those techniques into what we were doing. So that would be one. I think, again, and it's what we're trying to work on, as Lisa pointed out, an opportunity, but I think, the access to the data, that we've created these tremendous resources, but, there is the research, there's a barrier in terms of getting to the restricted data rightfully in a lot of ways, right? That we really want to protect the confidentiality of our survey participants, but that's where I think we really are embarking on some of these new opportunities and thinking about putting out synthetic data that, again, not fully synthetic, but, these limited files that, if we could put them out and then set up a mechanism to validate them, so that researchers would know, you're X% off your true, what it would be if you use the true data, and are researchers comfortable submitting that information to a journal article, or do they want to come in and use the restricted data? So I think, those are 2 barriers, but I feel like we're coming up with means to do this. And, and I guess even touching on the privacy preserving record linkage, I think we are often asked, well, can we link to this source? Can we link to this source? And historically, we haven't gone through third parties for linkages, but if we think about encrypted linkages where we may not have to share PII outside of the center, but you just share this encrypted ID that has no identifying information, that may open up opportunities to link to more sources across the healthcare spectrum. And I think in this time of COVID and thinking about how else could the linked data be used, and are we missing out on opportunities? So we're looking into these things, and I think it is a really exciting time to be in linkage. So we're there are challenges, but there's a lot of fun opportunities.
Great. So I think we're getting towards the end, so I'll finish up with this last question around, particularly around data modernization and data timeliness. And so what work's underway to really improve any of the data timeliness with the linkages?
Yeah, I mean, I think the main things in the, when asked about timeliness, I mean, I think a lot has to do with the sources we're linking to, right? So, if we think about CMS data and we want to link to those final adjudicated files, right? And so the time that, we just finished a linkage, and what we're getting ready to put out shortly is it has Medicare data through 2018. And that really was the most recent linkage that we had. So, I mean, I feel like we are pretty timely in that sense. And similarly with the NDI, we haven't yet put out, like the 2020 data is not there, but the 2019 are, and we are linking to that. So I think it really is, it's as administrative data get more timely, that we will keep up. And I think that's one of the things we've really been working on, and having that infrastructure and having our kind of programs ready to go when the data are ready. So I guess it's just across the board, as things get more timely, we'll join them.
Great. Well, thank you, Lisa.
Thank you.
And thank you everyone for attending today's NCHS webinar on the Data Linkage Program and on World Statistics Day, no less. If you have any questions or comments not addressed in the webinar, please email paoquery@cdc.gov. That's paoquery@cdc.gov. Thanks all. Thanks, Lisa.
All right. Thank you, everyone. It was a really fun session and great questions. So thank you.